going to record this for the people who are unable to join us so they can tune in later. This is our fourth speaker session for healthcare practitioners, and tonight we have Dr. Soni Sierra with us. So Dr. Sierra is going to be talking about recurrent loss, which is one of her specialties. She is, as you know, a reproductive endocrinologist and infertility specialist, and she is a partner at Trio and also the medical director at Evolve, the egg freezing clinic. In addition to her fertility practice, her and Dr. Carl Laskin, who is also at Trio, run the Early Recurrent Pregnancy Loss Program, which is the largest program of its kind in Canada, which is why she is heading the talk here tonight. She's also an associate physician at Women's College here in Toronto and an assistant professor at the University of Toronto. And the past year, she just became the president of the Canadian Fertility and Andrology Society. So I will let her take it away. And if I've missed anything, she can add in there. As always, if there are any questions, please ask them in the Q&A at the bottom of your screen, and she will be taking questions when she gets through her talk here.
Okay, so thank you for that.
Oh, do you want to share did you share your screen?
I'm going to share right now.
Okay.
Okay, so thank you for that introduction, very thorough introduction. I can't see anybody, so it's like I'm talking to myself, but I have a lot of slides. It's a big topic, but I'm very, very happy to stop and be interrupted. If you have questions, I guess you can just speak out or
so because it's a webinar, they have to put them in the Q&A, but if there's any going along, I'll pose them to you as they come up.
Okay, perfect. Okay, all right, so we'll talk about recurrent pregnancy loss. One second, down here, okay, sorry. So objectives to define what we mean when we say recurrent early pregnancy loss, to discuss when and how we would investigate, and then review some of the management options. Majority are empiric, but we will review some of the evidence. So to begin any discussion on miscarriage, I always start with this slide. This is also a way I usually start consultations when I see patients for recurrent pregnancy loss. And it's just to sort of appreciate that all the babies we see are really the tip of the iceberg. From the time conception happens, before we recognize a pregnancy as a pregnancy with a heartbeat, we estimate that there's about 60% pregnancy loss rate. Most of the time, prior to even acknowledging a pregnancy is present, we call them preclinical losses. And then once a heartbeat is detected, there's still a maybe 10 to 15% loss rate. And then once you hit 10 weeks, then that loss rate is significantly reduced. So it's very much part of how we are so inefficient at reproduction, and a lot of pregnancies are lost early. And sorry, just to review in sort of table form, and the risk of pregnancy loss prior to 6 weeks can be as high as 50%, 15, and then less than 2. But the interesting thing is back in the 80s, when our technology, our skills at chromosomal analysis was still rudimentary, we found that about 70% of those early losses could be cytogenetically abnormal. So a lot of them due to random genetic bad luck. In other words, there's nothing that you could have, would have, should have done differently to prevent that miscarriage from happening. And that's still the case, maybe 6 to 10 weeks. But again, once we hit 10 weeks, then the chance of loss goes down significantly. And the chance that that loss that does happen is due to random bad luck is also reduced. So despite the frequency with which miscarriage happens, or how common it is, it's a very traumatic process for people to go through. We think that 40% will go through a typical bereavement process, similar to carrying a baby through term and then losing. Emotional reactions reported include numbness, disbelief, withdrawal, anger, guilt, sadness, anxiety, and depressive and anxiety symptoms after a pregnancy loss within the 6 months is at baseline 2 to 4 times higher than the general population. So it's even more difficult when people undergo recurrent early pregnancy loss, and we define that as 2 or more failed clinical pregnancies as documented by ultrasound. That was our classic definition. And then an even more traditional one was 3 consecutive losses. And we think from those early papers that 5% of women have 2 losses and a smaller percent experience 3 consecutive. But what about non-visualized pregnancy losses, which are reported more widely now because we have these amazing pregnancy tests that at home can predict early pregnancies. And so we get a lot of early pregnancy losses. So non-visualized pregnancy or biochemical losses or pregnancies of unknown locations are the common terms that we use to describe those early losses. And the European guideline that just came out this year, and I think it was updated this year from originally published in 2020, shows that these losses actually do increase the risk of previous losses. So we do include non-visualized pregnancies as part of the definition of recurrent pregnancy loss. So for instance, I will see a couple in consultation or a patient in consultation if they have a history of 2 or 3 biochemical losses consecutively. So we talked about how it's part of our normal inefficiency of reproduction. So should we even investigate? Should we pay any mind to recurrent pregnancy losses, especially those biochemicals? But we should, because couples want to know why, and they want investigations. And these were demonstrated by a couple of qualitative studies that showed that people do want to know the underlying cause of the pregnancy loss, and they're also hoping to get subsequent pregnancy care early in the next miscarriage. And that study wasn't actually in an RPL population, that was just in people who experienced a miscarriage. And then a study similarly done in a specific recurrent pregnancy loss population stated that people want to know the reason for the losses as much as they could, even if there wasn't any subsequent clinical guidance or support. The other important reason we should pay mind to recurrent early pregnancy loss is because of the mental health impact I alluded to earlier with the increased depression and anxiety. And there's been some papers in late 2015, 2016, where specific to recurrent pregnancy loss, there was moderate to severe depression reported in just under 10% of women with recurrent loss, as compared to 2.2% in just the population trying to get pregnant. They also reported a very high level of perceived stress in women with recurrent pregnancy loss compared to controls, and that's controls of people just trying to conceive. So when should we investigate? So classically, again, the classic definition was 3 consecutive losses. So we often got referrals, or people waited to be referred until they had 3 consecutive losses. But recent data support evaluation just after 2 losses. And as I mentioned, that includes these early biochemical and non-visualized pregnancy losses. And the reason is that I mentioned before, but there's an increasing risk with every subsequent pregnancy loss beyond 2. And I'll demonstrate that a little bit further. So what should we investigate? So we should investigate, or we should talk about history. So details around each pregnancy. When was the pregnancy loss diagnosed by ultrasound? Was there documentation of fetal heart or not? And crown rump length at the time of demise, because that helps us decide what are the chances that pregnancy loss is due to random bad luck, or is there some other etiology? And we know from early studies that the 2 most important determination of future pregnancy success are maternal age and the number of previous losses. So this is something that's probably well known to all working in female health, that with increasing maternal age, there's an increasing risk of pregnancy loss due to egg quality issues, due to aneuploidy. And then this is a really useful chart that shows the increased risk of spontaneous loss with increasing number of previous losses. So you see after 2 previous losses, the risk of pregnancy loss again goes up to 25%. After 3, it's 45%. after 4, there's more than a 50-50 chance that you'll have another miscarriage. So these patients definitely warrant referral investigation. This is a really useful chart that people working in recurrent pregnancy loss refer to all the time. And this is an important thing as well. So part of the reason we should see patients after 2 or 3 losses is with every subsequent loss beyond that, the chances that the pregnancy loss is due to a normal karyotype decreases. So miscarriage with normal embryonic karyotype increases with prior pregnancy losses. So again, when we talk about majority of losses are due to random genetic bad luck, we can't give that reassuring message after 3, 4, 5 pregnancy losses. So again, going back to the history, so taking a thorough history, understanding the number of previous losses, the stage that they happened. Important in that history is also to talk about lifestyle risk factors. So a lot of this data comes from the general reproductive population and not necessarily RPL, but it's important to take information about smoking, as we know that there is a dose-related response with smoking and next pregnancy loss. Caffeine, again, dose dependent. There's a linear association between daily caffeine intake and the risk of multiple losses. Moderate, even 150 milligrams per day, may also increase the odds of recurrent pregnancy loss. Alcohol, there's no consistent evidence. I think there was one case report study that said that even 2 to 4 drinks per week can increase risk of loss, but it wasn't a very well controlled study, so I'm not sure how valid that is. And we don't have specific data in the recurrent loss population. Exercise is another one that definitely comes up during these consultations, because sometimes women feel that they exercised too much or were too hard on their bodies and subsequently had a loss. But we advocate exercise in this population of recurrent pregnancy loss for a number of reasons. It's beneficial, and there hasn't been any indication that there's increased risk of sporadic loss in women who exercise versus those who didn't. Okay, and there was an eager study which looked at the effects of aspirin, and part of that they did a subgroup analysis with over 1,000 women who had 1 or 2 pregnancy losses, and they found that if people had a higher BMI and they walked on a regular basis, then they had a lower risk of miscarriage. Obesity is an important thing to take into account when assessing these women or taking a history. And this data is pretty convincing. So there was a study of women who had 2 or more losses, over 300 women, and it was a very well-designed study, including follow-through of subsequent pregnancy and then cytogenetic analysis. So looking at the pregnancy tissue to determine the genetics. And they found that in women who were obese, they had a much higher chance, a risk of having a pregnancy loss compared to those that were not obese. And that pregnancy loss was more often a euploid. In other words, they're losing pregnancies that are otherwise genetically normal, and therefore outside of random bad luck, and therefore BMI seems to be a risk factor for pregnancy loss. BMI over 30. So again, outside of those lifestyle factors, what are the other things that we look at? We look at anatomic defects in recurrent loss. So when you look at population-based studies with women who had 3 or more losses, they found that 10 to 15% had some form of anatomic issue, whether it was congenital, such as a uterine that had a septum, or a bicornuate, or if it was an acquired anatomic defect, such as endometrial polyps, fibroids, or scar tissue. The acquired ones can be amenable to surgical correction. However, the data is really sparse in this area. It's really lacking. We think that septum, it makes sense that it can be associated with recurrent loss, because if a pregnancy implants on a septum, it won't have the same blood supply and environment for implantation. And in a meta-analysis or a summary of several studies, they found that the risk is somewhere between 6 and 16% in people, or sorry, not the risk, the incidence is about 6 to 16% of having a uterine septum in a population with recurrent loss. However, again, we need surgical trials. And right now there's insufficient evidence to support resection of a submucosal fibroid or polyp in these patients with recurrent loss. However, it's hard to sort of feel reassured telling a patient who's had multiple pregnancy losses in the face of a finding of a polyp or fibroid. I think most of us would recommend that is removed, even though we don't have the evidence to say so. We investigate endocrinology or hormonal environment, untreated hypothyroidism, abnormal glucose metabolism, hyperprolactinemia, and then this sort of foggy area of luteal phase deficiency. So thyroid dysfunction, there's no actual clear association between thyroid function and subsequent pregnancy outcome, but we do believe that a euthyroid state is optimum. And especially in the area of early pregnancy loss, we don't have a lot of data. We know that if you have treated thyroid disease, it's not associated with recurrent pregnancy loss. And there's some studies to say that TSH over 2.5 can be found with higher prevalence in women with 2 or more losses. But live birth data don't show much impact. And this finding of TSH or subclinical hypothyroidism was replicated in subsequent retrospective studies. So an association is implied, but it's not definitive. Autoantibodies is another area that people were looking at in the 2000s because, again, there may be an association based on retrospective population data for thyroid peroxide autoantibodies. But again, there's no definitive treatment recommendations that come from the evidence that we have. Hyperprolactinemia, elevated prolactin, old studies demonstrate maybe a prevalence of about 3.3%, not enough evidence to establish a clear link. But in the late 90s, an interesting single small RCT that was very well controlled demonstrated that if we treated with prolactinemia in the face of hyperprolactinemia, if we treated with bromocriptine in the face of hyperprolactinemia, there was an improved live birth rate. So at present, it's not a strong recommendation that we screen, but if symptoms suggest, then it's worth to do a prolactin level. Vitamin D is an interesting factor in recurrent pregnancy loss. There's been some meta-analyses done recently that showed that women with 2 or more losses have a lower vitamin D circulating than controls. It might have some endocrine implication, but it also has immunomodulatory properties and may impact on endometrial function around implantation as well. So they also found interesting linking to the immune system that women with vitamin D deficiency also had a higher prevalence of other antibodies. And treatment studies are lacking, and there's small numbers in those papers that showed that prevalence, and not a lot of data suggesting the benefit of vitamin D therapy. So we don't have clear evidence to say we should definitely screen for vitamin D and treat vitamin D, but it makes biologic sense to add that to investigations when seeing patients with 2 or more losses. Endocrine factors. So there seemed to be a higher incidence of insulin resistance in women in one small paper, but there's no routine screening outside of having symptoms or other risk factors for insulin resistance. PCOS is associated with several pregnancy complications, and we think also pregnancy loss. There's association with PCOS and obesity, LH dysregulation, hyperandrogenism, and that luteal phase defect. So it can possibly contribute to recurrent pregnancy loss, but there isn't a lot of clear data on an association or treatment. So moving to endometrial factors, Tavia, you'll keep me in check for time, right?
Yep.
Okay. Endometrial factors. So this is really an interesting area, and this is where we were really good in fertility medicine in treating many things, but the endometrium is still a black box. We think based on really old classical definitions of luteal phase deficiency, we thought that accounted for up to 20% of patients with recurrent pregnancy loss. And those were classic studies where biopsies were done around day 21 of a cycle and then sent off for histological analysis to indicate if it was secretory, as should be at that time of implantation. And if not, the treatment was given with progesterone, and that's how it was classically done. But again, documentation of benefit was lacking. We believe it makes sense because from classic studies, we know that there's an optimum day of implantation. And if pregnancies do implant past that day, there's an increased risk of pregnancy loss. And outside of the luteal phase deficiency, we looked for other clinical markers for issues in the luteal phase, including mid-luteal progesterone level. But again, there isn't a lot of evidence to state that that's a valid and reproducible finding to diagnose an issue. Other markers for endometrial receptivity during that luteal phase that have been looked at: cyclin E, progesterone receptors, IGF-BP, apolipoprotein D, glycogen. All of these things you can find in basic science papers, but we don't know what the clinical significance is, nor do we have tests readily available to look at those things. If we look at what's involved in implantation, and this is one of my favorite images because it really shows the multitude of vascular and immunological factors that take place to allow for successful implantation. But if you look at it, you can see that a lot of the immunofactors and vascular factors are modulated by progesterone. So progesterone in the luteal phase, made usually by the corpus luteum after ovulation, has to play a central role. And for years, we've been looking at progesterone, giving progesterone support in early pregnancy. And that comes from really old studies in the 70s that showed if you give progesterone receptor antagonists, so you block the action of progesterone, you could induce pregnancy loss prior to 7 weeks. Similarly, surgical removal of the corpus luteum, which is the powerhouse of progesterone production in early pregnancy, removal of that resulted in pregnancy loss as well. So there's a lot of evidence to suggest progesterone plays a very important role. But it's interesting that not until 2019, 2020 did we have really good randomized controlled evidence. And then we had 2 papers that were very exciting for us working in fertility medicine that were published in the New England Journal, because we never get papers published there. But one was the PROMISE trial. Subsequently, there was the PRISMS trial. So these were done in Centers for Recurrent Pregnancy Loss in the UK, where they have a large network of clinics. The prevention trial looked at the role of progesterone in recurrent pregnancy loss, and the rescue trial looked at the role of progesterone in the face of threatened pregnancy loss or bleeding in the first trimester. So the first study, again, looked at recurrent pregnancy loss, those trying to conceive naturally. They were given 400 milligrams of micronized progesterone taken twice daily, no later than 6 weeks until 12 weeks of pregnancy. And they randomized those with 3 or more losses into those who got treatment and those given placebo. And the outcome was 24 weeks, beyond 24 weeks of live birth. They had 825 people randomized. And unfortunately, they did not find any difference in the live birth rate with progesterone versus placebo groups. However, the authors talked again in the discussion about how they remembered this chart and how the risk of subsequent pregnancy loss increases with respect to losing normal embryos with greater numbers of previous losses. So they thought maybe there's a dose-dependent effect. In other words, maybe with more pregnancy losses, we'll see more of an impact of progesterone. And so they did a subgroup analysis in this paper, and they found that when there were 3 losses analyzed, there was a slight increased benefit to progesterone. And when they looked at the patients presenting in the trial with 4 or more losses, they found an even more significant favoring of progesterone. And so you can see it in that chart. And so they designed a second paper to look at that a little bit more in depth. So this wasn't in a population with recurrent pregnancy loss, but it was in women presenting with early pregnancy bleeding. And their question was, in the face of threatened miscarriage, if we gave progesterone, is it a benefit? So again, similar treatment, 400 milligrams of progesterone taken vaginally from the time they presented with bleeding until 16 weeks of pregnancy. And they randomized 4,000 women compared to placebo. And here they found a trend with an improvement in live birth in the progesterone group. Very, very tiny trend. So live birth rate was 3% higher. And they translated that to mean there were 54 extra babies in the progesterone group. And so they found this to be borderline statistically significant. But they actually...
Oh,
yeah.
there's a question about, so when's the progesterone is started in that group as soon as there's bleeding, or it's a pre-treatment in a certain population, like as soon as they're pregnant or trying to conceive?
So the first paper,
The one you're talking about
yeah,
now.
this paper, it was started when they presented with bleeding.
Okay.
Okay. So this paper, however, was powered sufficiently, huge numbers, to look at the question of recurrent pregnancy loss. So they looked at it the same way, no losses 1 to 2 greater than 3, and they found with increasing numbers of previous losses, they found a significance. In fact, they found that with even 1 or more loss, there was a statistically significant favoring of progesterone in terms of live birth. So this is just showing it in chart form. And then they looked at sort of the totality of evidence we have with progesterone. So years and years of tiny studies, but looking at it as a whole, there seems to be in the patients with recurrent pregnancy loss, 3 or more previous losses, there seems to be some favoring of the use of progesterone. There isn't a lot of side effects or safety concerns with progesterone used vaginally as they did in these 2 trials. And so this is just a summary of the PRISM trial. So if patients present with vaginal bleeding at 12 weeks of pregnancy with no previous losses, there doesn't seem to be any benefit and standard of care can be offered. However, if there is bleeding less than 12 weeks and there's 1 or more previous losses, they're suggesting vaginal progesterone at a pretty high dose, 400 milligrams. We don't give that. I usually give 200 twice daily. But here they found that the number needed to treat to take home a subsequent live birth in a population with 1 or more losses, 20. But if there's 3 or more losses, it's pretty significant, 8 people to treat to improve the live birth rate or take home a baby. So progesterone, there seems to be some benefit. So moving from progesterone to look at the question of chronic endometritis. So that's an infection deep in the lining of the uterus. They think that in the population with recurrent loss, there's a 10 to 27% prevalence. And it has to do with sort of infiltration of the plasma cells into the lining, creating this environment of chronic inflammation, potentially altering gene expression of all of those vascular cascade and immune function, and decreasing endometrial receptivity. So classically, we do an endometrial biopsy and look for plasma cells and immunohistochemical stains for CD138, which is the marker for plasma cells. And there seems to be some variance, so anywhere from 50 to 80%, around 50% in patients with recurrent pregnancy loss we find in patients with recurrent pregnancy loss, about 56% of them have CD138 positive findings, and the live birth rate in these same women, if we don't treat it, is 67% compared to almost 90% in those women who don't have chronic endometriosis findings. So when we look at CD138 or plasma cell incidence in those histological stains, there's some variance in the data. Some studies quote 30%, some studies quote 60%. So we're not sure what the actual prevalence is, but there does seem to be benefit to treatment. And in terms of what specific treatment, we're not sure. If we're treating endometritis, typically it's a 2-week regimen. Nobody has looked at if a test of cure is important, and nobody's done longitudinal studies to see what obstetric outcome might to see if improved obstetric outcome in patients who are treated. Other infections that may be at play in patients with recurrent pregnancy loss, or that we've suspected, ureaplasma mycoplasma, which could be passed between partners, chlamydia, chlamydial antibodies, but again, very much a lack of literature documenting a clear association or a clear benefit to treatment. So that was then, and now we have better technology to look at the uterine microbiome. There is a commercially available test, which is a biopsy that patients will pay for, that will tell us about the uterine microbiome, so the presence of both good and bad bacteria that should be there in a healthy endometrium. And secondarily, it will also tell us if there's any pathogenic bacteria, and sensitivity. So what specific antibodies? So it's an ongoing area of data collection. And we're learning a lot about, the importance of lactobacillus in the endometrium and how to treat any other pathogenic bacteria. Immunological factors, this is probably the area we have the most data in, antiphospholipid syndrome, looking at antibodies in early pregnancy loss. And we think that there's an association of about 15% antibodies in patients with recurrent pregnancy loss. Specifically, the antibodies we look at are the lupus anticoagulant, the anticardiolipin antibodies, and anti-beta-2 glycoprotein. And there's an association between these antibodies, not just in early loss, but obstetric outcome as well. We think that they induce thrombosis in vessels that surround the maternal placental unit, and they interfere with the invasion of the trophoblastic cells into the endometrium, and starting laying down roots for a healthy placenta to take place. To diagnose, we need 2 positive tests, 12 weeks apart outside of pregnancy. So the diagnosis can take up to 3 months, which is a long time for patients to wait when they want to get pregnant. So we do anticardiolipin antibody testing. And like I said, they have to have 3 consecutive losses to meet diagnostic criteria. So 3 consecutive losses or outside of recurrent loss, neonatal death, or preterm delivery, or a history of vascular thrombosis. So if these antibodies are found and a diagnosis is made and we don't treat, the chances to take home a baby are less than 10%. And treatment with low-dose aspirin, so 81 milligrams, as well as low molecular weight heparin, can improve pregnancy rate, take-home baby rate, to about 80%. Inherited thrombophilias. So this is something that, you might see people ordering with a history of recurrent early loss. However, the data doesn't suggest that it's always necessary in terms of association or treatment. So inherited thrombophilias include prothrombin gene mutations, factor V Leiden, protein C and S deficiency, MTHFR mutation. And the issue is that a lot of these things are found as normal variants in healthy reproductive population. So the retrospective data has always documented some association, but when we've looked at it prospectively, there doesn't seem to be any confirmation of those findings. And then recently, even though we know that it's not clear association, there was a 12-year prospective study called TIPS that looked at treatment of inherited thrombophilias in women with a history of recurrent loss, and they didn't find any benefit to treatment in terms of take-home baby rate. You might come across patients who have...
Can I pause you for a minute? I just had a few questions come in about for patients who might have a family history of recurrent loss. Is there something that should be done or could be done when trying to conceive, when you're looking at some of this historical, if or genetic data?
Yeah, I think with the genetics, which I'm going to get to, I
Okay.
think, well, that's where family history of translocations and pregnancy loss might come into play. Also, autoimmune issues do sometimes come in families. So in that scenario, we should also pay attention to family history.
So so then an add-on question to that looks like if I'm assuming a family practitioner is referring to you, what sort of information do you need? Or tests? Do you do all the tests, or do they need to run some tests, or what sort of documentation do you need from the family physician on patients that have
So
recurrent loss?
yeah, when I come to the end slide, I'll go over
Okay.
that. But I think like for now, just taking a thorough history and sort of being aware of the things that might be associated with recurrent loss, and highlighting those and sort of making the referral or deciding on when to refer.
Okay.
Um, so we don't have to get into these autoimmune factors because we don't have a lot of evidence, but genetic factors. So I mentioned that aneuploidy or random genetic bad luck is the most common reason for early loss. And then genetically, the next common reason is the balanced structural chromosome rearrangement, which might be prevalent in family history. There are other genetic disorders that may come into play. So expression of genes involved in immunity, angiogenesis, apoptosis pathways, genes that are looking at thrombophilia or placental function, immune responses I mentioned, all those things. If there's a history, family history of that, and patients had pregnancy loss, one or two, it's something to sort of be aware of in terms of a screening and early referral. So structural chromosome rearrangements I mentioned is probably the most common outside of random genetic bad luck. They occur in 1 to 5% of the normal population. Reciprocal translocations are the most common. And pregnancies with unbalanced chromosome rearrangements often end in pregnancy loss. The prevalence of an unbalanced karyotype in an ongoing pregnancy is really, really low. Most pregnancies with an unbalanced karyotype don't result in a live birth. And if they have a balanced karyotype, so in other words, if they have a translocation, a piece of a chromosome is missing on one set and attached onto the other, so that's a balanced rearrangement, their take-home baby rates are still excellent, 83 to 84%, and they might not ever come to our clinic. So routine karyotypes are not part of a workup for RPL as per most national guidelines. However, if there's a family history suggesting recurrent pregnancy loss or fetal loss due to genetic reasons, it could be a reason to order karyotypes, even when presenting for routine family care prior to referral. So if there is a balanced translocation or a structural chromosome rearrangement, what we can do in fertility treatment is talk with them about pre-implantation genetic screening or testing. There does seem to be some evidence of decreased pregnancy loss, but we have to be careful because even though we do see a decreased pregnancy loss, and some studies document a decreased time to a healthy pregnancy, the ongoing pregnancy rate isn't that different from natural conception. So it just has to do with, if you have a couple that has a known genetic issue and they've seen genetic counseling and they say that your outcome to eventually take home a baby is still quite good, they might not necessarily need any fertility treatment further if they have the buffer to continue to try. Embryonic aneuploidy, so abnormal pregnancy loss tissue, can be found most commonly in pregnancies that are lost prior to 10 weeks. The most common abnormalities that we see are trisomies, polyploidies, or monosomy X. And as I mentioned prior, that there's an increased risk of having these random genetic losses with increased maternal age. And this is sort of a really interesting basic science paper that demonstrated maybe a quality control mechanism that's off in patients with recurrent pregnancy loss. So there's some evidence to say that the lining of the uterus is actually a sensor of embryo quality. So this is a slide with decidual tissue in a healthy lining. So in the face of no embryo, there's no reaction. It's a very quiet endometrial lining. This is to demonstrate the same. In the case of a high quality embryo, there's an interaction between the lining and the embryo. In the face of, so this is normal healthy controls, this is recurrent pregnancy loss models. And so when you have a high quality embryo in both of these situations, there's a decidual reaction, this jagged edge in both of the situations. And so pregnancy starts to get implanted. But in the healthy controls, if you give a low quality, a genetically abnormal embryo into that endometrium, there's no decidualization reaction. So it's almost like the endometrium, with crosstalk between the embryo and the lining, knows it's not a good quality embryo. In a healthy control, there's no implantation. But if the same embryo, genetically abnormal, is put into the lining of someone with recurrent pregnancy loss, there's the same decidual reaction and it implants. So these sort of basic science studies indicated that maybe the lining is a sensor and it's a faulty sensor in patients with recurrent pregnancy loss. And so that might indicate they would benefit from genetic screening. So not introducing into the endometrium or into the uterus of women with recurrent pregnancy loss genetically abnormal embryos, because they'll hold on to them regardless, and then eventually have a loss. So knowing that, we expect genetic testing to lead to a higher chance of taking home a baby and a lower risk of miscarriage. And the data isn't solid, but it does show perhaps some favoring to this technology in patients with a history of recurrent pregnancy loss. So essentially taking taking patients who have no trouble getting pregnant and putting them into an IVF cycle to screen for random error, and therefore only giving embryos that are genetically normal. So despite all of that, we do find that 50% of patients presenting with recurrent loss, we won't have an explanation. So there won't be any genetic issues, no genetic history, no anatomic factors, no autoimmune infection or endocrine. So from that, I'll just go a little bit into this, that we think it's 50%, but if we add genetic testing to the second pregnancy loss, then the chance of finding nothing wrong or finding an unexplained risk of loss is less than 5%. So this study sort of shows, let me just see. This study shows an algorithm, a way of managing recurrent pregnancy loss that will lead to better diagnosis and less testing for patients. And this is something that hopefully you can do in a family medicine office as well. So first pregnancy loss, patients are counseled, supported. They go on for achieving pregnancy. And then in the case of a second loss, this paper suggests that we obtain products of conception and send them for genetic screening. And if we do, and we document that the products of conception were abnormal, you don't have to do anything. You don't have to refer those patients. You can just reassure them that that pregnancy loss happened because of random genetic bad luck, and they can go ahead and try again. However, if the pregnancy loss tissue comes back and documents an unbalanced chromosomal rearrangement, then you should order karyotypes. And if it comes back and subsequent referral, genetic counseling and fertility treatment, or if you do the testing and it comes back that the pregnancy loss was genetically normal, that's when they need to be referred for a full workup of all of those other factors we talked about and potentially treatment. And like I said, if we do it that way, then the risk of having unexplained loss is 5%. And we would have a much higher pickup in terms of making a diagnosis, either an abnormal workup that I just went through or abnormal products of conception in 95% of cases. So when we get those truly unexplained, what do we do? Well, low dose aspirin, probably you guys have heard about. fragment, progesterone, IVIG. People do leukocyte immunotherapy. They do corticosteroids. They do IVF with genetic screening. All of those are treatments that people try in this area, but interestingly, none of them are supported by evidence. We do find, however, an improved take-home baby rate if we don't do any of these things, but offer a lot of supportive care. So what does supportive care look like? It can lead to almost an 85% live birth rate in some papers, and there's been multiple studies, a lot of them from non-treatment arms and other treatment trials, but studies from 1954 until 2000 show that there's an increased live birth rate. And when does supportive care? Well, it starts from the time that a patient visits with a specialist or, presents with a history of recurrent pregnancy loss. And when they looked at qualitative studies to say what do patients want when they have a history of miscarriage, they want early and frequent ultrasound. They want beta HCG monitoring, I guess, before the ultrasound. They want practical advice on lifestyle and diet, emotional support and counseling, and they would like a clear policy for monitoring during the first trimester. What they find is not helpful is too many ultrasounds, complementary medicine, so looking at herbal remedies, etc., and hospital admission is not helpful. So summary points. Recurrent loss is a difficult problem for patients, affects about 5% of our reproductive aged patients, and investigation and treatment should be directed to the etiology. And we don't have a lot of data, so it's difficult to ascertain. But what we do know definitely is that there's a higher risk of pregnancy loss with every previous miscarriage beyond 2. It has a big impact on mental health. Patients want to be heard. It's an excellent opportunity for counseling that starts in the GP office for sure. Investigations can be tailored according to history and risk factors. There is some evidence for using progesterone empirically. Products of conception testing should be done after the second loss or with the second loss whenever possible. And according to the evidence, the best treatment we have is actually supportive care. So seeing these patients, talking to them, defining a plan of management. And I think it's always important to remember that given patients with recurrent loss actually have an excellent prognosis to eventually take home a baby, regardless of the etiology. So we have to be very mindful that the patients are also very, very vulnerable, and we shouldn't be exposing them to unproven, expensive, invasive, and potentially harmful therapies, in my opinion. And that's all.
All right, thank you. Yes, that did answer some of the ones that came in. One I noticed, or two I noticed that didn't get answered. One, what do you recommend in terms of mental health supports for these patients, or is there a program that Trio offers or that you offer?
So the recurrent loss program that we offer at Trio, that includes myself, the doctor, we have a nurse practitioner that started, and we have a physician assistant. So our supportive care includes, consultation, follow-up, progesterone treatment that initiates either in the luteal phase if we're monitoring them or with a positive pregnancy test. We do 2 beta HCG levels in these patients, and then we do early ultrasound starting initially between 6 and 7 weeks, and then every 2 weeks until they go to the obstetrician. And during this time that they're in our office, usually until 10, 11 weeks, during that time, then they have access to our nurses and myself and the physician assistant I work with. That's what supportive care looks like in our office. In other clinics, they have similar models as far as I know, but it varies. I mean, family physicians can very well offer this exact same supportive care. It's just sort of having a plan, doing that early monitoring, plus or minus progesterone, and I think it has been shown to be beneficial.
And then just on top of that, what are your current weights for these for this program or for reproductive loss patients specifically? It asks.
So It varies, it does vary throughout the year. I'd like to say, with recurrent pregnancy loss patients, we get them in within 6 weeks, but sometimes just with scheduling, et cetera, it can be a couple of months until they're seen. We are increasing our program in terms of other doctors being involved and also the nurse practitioner and physician assistant to help us get through some of the new patients. But we try our very best within 2 months because recognizing it's most likely an aging population and patients want to get in quickly.
And do these patients have to have come through TRIO as IVF or IUI patients, or they can just be straight referred because of recurrent loss?
Yeah, no, we see them just for recurrent loss.
Um,
And recognizing they might never need IUI or IVF. But
okay. And then the last question I have here, it looks like, is what causes biochemical pregnancies to miscarry so early? Is this too hard to determine?
it's hard to determine, but we suspect that it's genetic. We suspect that when biochemical losses happen, most often it's because the embryo is not normal genetically or perhaps not strong enough. In the case when we're doing in vitro and we get biochemical losses with euploid or genetically screened embryos, then we suspect maybe there's something in the lining. But for naturally occurring pregnancies, I think the most common reason for really early losses is going to be biochemical. It's going to be random bad luck. Yeah.
Well, that is all the questions that have come in for us tonight. So thank you so much for doing this talk. Oh, that's great to have the summary up there. And for everyone who joined us, thank you so much for joining us tonight. If you have any further questions for Dr. Sierra, you can submit them to myself and I can forward them on to her, or through the TRIO website as well. You can reach out to her, and I look forward to seeing you at other upcoming talks. And have a good night, everyone.
All right. Thank
Bye.
you.
Thanks.
Bye.